Good afternoon, evening, everyone. I wanted to take this opportunity to welcome everyone. My name is Judd Walson. I'm here on the faculty at the University of Washington in the departments of Global Health, Internal Medicine, Infectious Disease, Pediatrics, and Epidemiology. And I work quite closely with the Bill and Melinda Gates Foundation on a project here called the START program, which I'm going to talk briefly about. And we were approached by the Bill and Melinda Gates Foundation several months ago to see if we'd be interested in joining together in recognition of World Pneumonia Day and really bringing more highlighting this important issue of global health. We thought this would be a really great idea for several reasons. One is that what's, I think, becoming increasingly recognized around the world is that success in global health in many areas, including pneumonia, comes from partnership and from coming together with a variety of different groups. And universities certainly have a role to play, as does private industry, foundations, and many others. And so it's really a pleasure to be able to bring together a diverse group of people that are represented here in the room today to speak about pneumonia. And I'm excited that our speaker, who I'll introduce shortly, will be able to do that. I also wanted to just point out that there are a variety of groups here at the university who have been instrumental in helping to plan this, and I think are doing really relevant work in this area. So one, I mentioned the START program, Strategic Analysis, Research, and Training Program, is something that Lisa Manhart and I co-lead, and we work with graduate students here at the university to work on projects that are proposed by the Bill and Melinda Gates Foundation from a variety of different topic areas. And it really has two very important missions, and goals. One of those goals is to provide really high-quality deliverables to the foundation so that they can inform their programming. And the other goal, which we take equally important, is really to provide an applied learning experience for our students so that as they move through their education and then go out into the world to pursue careers in global health, that they're really one step ahead, having had the opportunity to do this. The other is that the University of Washington has recently started the Global Center for the Integrated Health of Women, Adolescents, and Children. This is a really exciting initiative that aims to have global breadth. It's unique in its life cycle lens approach to the integration of women, children, and adolescent health, and its focus on supporting discovery, leadership, and collaboration. And through this collaboration, it aims to foster new areas of research, create innovative solutions, and develop leaders who have the benefit of a multidisciplinary approach. And finally, we were also joined in this endeavor by Intersect, the International Respiratory and Severe Illness Center, which is based here at the University of Washington, and is working to improve health by reducing the burden of respiratory disease and severe illness in resource-constrained settings around the world by leveraging clinical research, educational, and technical expertise from the University of Washington to address the global public health challenges of respiratory and severe illness. So today marks World Pneumonia Day, and I think it really is fitting that we have Dr. Orin Levine here to share with us some of his thoughts about World Pneumonia Day and about pneumonia as a leading cause of childhood mortality around the world. Dr. Orin Levine leads the Bill and Melinda Gates Foundation's efforts to accelerate the introduction of new vaccines and related technologies and to improve routine immunization systems. He is the Foundation's focal point for engagement with the Gavi Alliance, whose mission is saving children's lives by increasing access to immunization in poor countries. Before joining the Foundation's Global Development Program very recently, he was a professor of international health and the executive director of the International Vaccine Access Center at Johns Hopkins University's Bloomberg School of Public Health. He's also served as a steering committee member of the Decade of Vaccines Collaboration and co-chair of the Global Access Working Group, as well as president committee on global health of the American Society of Tropical Medicine and Hygiene. He graduated from Gettysburg College before moving on to Hopkins Bloomberg School for his PhD in epidemiology. And there's really no one in the world more fitting to talk to us today on World Pneumonia Day. So with that, please join me in welcoming Dr. Levine.
I thought we'd kick off with a quick World Pneumonia Day video. Thanks. So I'm really pleased to be here with you guys tonight. I'm a pretty recent immigrant here to Seattle, having just started here on October 1st. And in fact, it's the first year that I've been on a World Pneumonia Day outside of the DC and Baltimore area where I've been for the last 10 or so years. And so when asked to talk tonight about World Pneumonia Day and pneumonia, I thought what I would do is maybe just tell you a little bit about pneumonia. I think you got the gist of the pneumonia messages there in the opening video. But then maybe tell you a little bit about World Pneumonia Day itself. This is now the 4th World Pneumonia Day, and hopefully conclude with a little bit about what I think is at the essence of World Pneumonia Day, and it's the people in this room and what we can do as individuals. So those are the things that I'm going to walk through tonight. How big a problem is pneumonia? I think we're in a global health community here, so it probably is not a big surprise to people here to hear these kinds of numbers, but it's more than 1 million child deaths in 2010. It's the #1 killer of children amongst all the illnesses in the total of about 8 million child deaths that occur, and it takes the life of a child about every 25 seconds. And these are statistics that people talk about all the time. But it's also important to remember that they're not just statistics, that they're also kids. And for me, that really rang through with the story of this woman here on the left. This woman, her name is Tiamani Diarra. And it just so happened that Tiamani and her husband had 2 daughters just about the same time that my wife and I had 2 daughters. They had a very different childhood, though. This is Tiamani sitting next to the bed of her second daughter, who is on her way to dying of pneumonia, 1 year after the older daughter died of pneumonia in the same bed in the same hospital. So to me, that really strikes me that the difference between Tiamani and my family is that her kids happen to be born in Mali. And the notion that there are things that we could have done to kind of prevent that suffering for that family that are not getting done is really, I think, at the heart of what we do on World Pneumonia Day. It's probably not going to surprise anybody in this room that the countries with the most number of pneumonia deaths are concentrated in Asia and Africa, and happen to be the kinds of places where they have very high rates of overall child mortality. They have generally weaker systems of immunization and health, curative care, and the like. I always like to call pneumonia, if you will, the biggest, most solvable problem in global health, because there are a lot of problems in global health that will take a lot to fix, and a long time, and a lot of work, and maybe feel sometimes like they're even beyond our control. But in the case of pneumonia, we actually have quite a lot of tools at our disposal right now. And there's a comprehensive package of interventions to protect and prevent children from getting these infections in the first place, or to treat them when they are ill, that can really help diminish the consequences of their illness. And it's things like breastfeeding and hand washing, vaccines, improving the recognition of the signs and symptoms when children are ill, and getting them subsequently the kinds of care they need with antibiotics or oxygen. And just to give an example of this from a perspective of vaccines, and one of the threads tonight in the talk is that I'm going to walk you through with a pretty personal narrative and my experience in this area itself. And one example is the pneumococcal conjugate vaccine trial in the Gambia, which I had the opportunity to work on. In this trial, the only difference between the two groups of children in this rural part of Africa was that one group got 3 doses of pneumococcal conjugate vaccine and the other group didn't. It's a randomized controlled trial. And the impact was tremendous. We had a 37% reduction in pneumonia, and we had a 16% reduction in all-cause mortality in this area, just from the delivery of those 3 doses of vaccine. And to put it into concrete terms, given the rates of mortality that were observed in this community, it was about 7 deaths that were prevented for every 1,000 children that were vaccinated. That makes these vaccines really powerful tools in global health, and really gives an example of what an important problem pneumonia is in those types of communities. So based on that kind of data and data for other interventions, the World Health Organization and UNICEF put together these projections that essentially, if we could scale up coverage of this package of interventions, improving case management, the treatment of pneumonia, HIV vaccine, pneumococcal vaccine, and breastfeeding, they calculated that up to 4 million deaths due to pneumonia could be averted from 2012 to 2015 by reaching those 90% levels. Now, we're probably not going to reach necessarily those levels in every country, but it's an indication of what we could achieve with that kind of coverage. Now, in spite of all this data that's really well known to us in the global health community, where we were sitting not so long ago was in an environment where global health donors were not aware of this data. So in 2003, I got a grant award from the Gavi Alliance when I was at Johns Hopkins for a project called the Pneumo-ADIP, and we were responsible for working with Gavi to help accelerate the uptake of pneumococcal conjugate vaccines in the world's poorest countries. We thought it would be a good idea to talk to some of the international donors and find out, what were they thinking about child health and where pneumonia was and those vaccines. So we did interviews with 30 leading global health donors in late 2004, early 2005. We asked them over 45 minutes about child health and those kinds of things. We asked them, what are the big killers? 0 out of 30 spontaneously offered pneumonia. And 9 out of 30, when asked, what's the leading cause of child deaths? They said AIDS, TB, and malaria. Now, that was not the case when you went and talked to the people who worked in developing countries themselves. They knew that pneumonia and diarrhea were the leading killers. They knew that neonatal was a big problem. But the people who were programming billions of dollars in global health funding were not aware. So, and if you need another example of this, this is a paper that was published in Science where they compare the burden of disease from different diseases and the amount of research funding that's directed towards it. And so you can see the burden of HIV, AIDS, malaria, and TB in the sort of gray bars. And then the red bar is bacterial pneumonia and meningitis. That's over on the left-hand side. And then you can see the R&D funding. So it was clear that in that environment, people were not making funding programming decisions strictly on the basis of disease burden information. So it was in this background and environment that World Pneumonia Day got created. Now, it's not like World Pneumonia Day had never been talked about, right? If you go and you work with any advocacy firm or PR firm or whatever, and you say, I've got a disease and a cause and all that kind of stuff, the first thing they'll always say is, well, you need a day, right? I'll tell you, they're not worth their salt if they don't come up with that to begin with. But so we had kicked it around, but we'd never really gotten around to it because we had a bunch of other things going on and stuff like that. And then this guy turned out to be the spark. This guy up here, this is Lance Lafer, and he's a hedge fund manager. This is not the community that we typically expect to be at the center of social justice initiatives. We can all laugh, but we need to give him due credit. So, and he's no ordinary hedge fund manager, by the way. This guy's a little bit different. So Lance had been working on malaria for years. And Lance is really clear. He said, one morning I'm up and I'm listening to Charlie Rose on TV talking to Ray Chambers about malaria, and I found out all these, problems with malaria, and I said, somebody's got to do something about this. And so we started Hedge Funds versus Malaria. So then he goes to a meeting called by Save the Children in New York, and he meets a guy named David Marsh, who's a pediatrician at Save the Children, who's been involved in community case management programs around the world for many years. And David says, as he will in his opening statement, pneumonia kills more children than any other disease. Lance approaches him with his vast understanding of global health statistics and says, you're wrong. And David says, actually, I'm not. And Lance says, this is outrageous. You cannot tell me that pneumonia kills more children than any other illness. I've been doing all this malaria stuff. How come people don't know this? This is outrageous. And he then writes an email later that night, as he will, and says, I'm going to declare World Pneumonia Day on April 1st. This is like February 26th, let's say, right? Maybe it's early March. I'm going to declare, and it's going to be April 1st, and it's going to be April 1st because we've all been fooled, and so it's going to be April Fools, and he just got all these things going on in his mind. So this provokes a series of emails, as it will in the technical community. Oh my God, this guy's going to call World Pneumonia Day. What are we going to do? So we get on the phone with Lance, and I called him to talk to him about this, saying, we talked about this before, and maybe this is a good idea, and we'll get on this. And I still remember first conversation with Lance was about an hour that we were on the phone, and I would say he talked nonstop for about 50 minutes of it. Hi, this is Lance, and just went on, and about the outrage and what needed to be done, and 1,000 different ideas. And we basically convinced him, look, you've sparked us into action. Let us have until November. And I went through a bunch of papers and convinced him that the seasonality of pneumonia was such that more pneumonia cases occurred in the month of November than any other month of the year, and he was assuaged by that. I actually did use some papers and data, but it wasn't exactly IHME type modeling. It was more kind of, like that. And so we settled on November 2nd. But that's really the spark. And the beginnings of World Pneumonia Day were quite humble. So there was basically a small group of interested parties, the coalition, the willing, whatever you want to call it, that managed to get together in late June, early July, in person after a lot of teleconferences and stuff like that, in New York. We didn't have any money to rent a hotel meeting room or anything like that. And Lance had a friend who knew somebody who could talk to somebody at NYU Medical School. And they said, sure, we got a room for you in the basement with no windows, and you can use it in the middle of summer for free. So we took it. And this is the group of folks that sat in that room that day. It was a really interesting group. It was Lance. It was people from Johns Hopkins. People from PATH were there. People from Gavi Alliance. People from WHO and UNICEF. The guy in the middle here was from the Gates Foundation, Richard Adegbola. And the guy standing up here, David Rubenstein, was he was better known originally as the executive director of the Save Darfur Coalition, who then came to child health and pneumonia and said, this is outrageous and we need to do something about it. So we got together in this room, and we planned our first World Pneumonia Day, November 2nd, and we had an event in New York to kick it off. And so after that, we all got together, and we had this great idea to wear blue jeans, because blue is the color of pneumonia. This is another Lanceism. Lance found out that kids with pneumonia get cyanotic, and somebody told him they turn blue, and so he decided that everything should be blue. And somebody else came up with the idea to wear blue jeans. And I have to say, anybody who came up with the idea to wear blue jeans did not live in Seattle, because it's like, you can't tell it's a special day around here. But in New York City, a bunch of guys show up in blue jeans, and people turn their head. And we managed to put together about a coalition of about 140 signatories to a statement joining the coalition, and started to get some traction, some action from people. We got some media coverage. So our master of ceremonies here is this is Richard Besser. I don't know if you guys know Rich. He was the CDC director during the pandemic, and has then gone on to join ABC News as their senior medical correspondent. So you might see him on ABC News with Diane Sawyer and other things. So I want to give, so the theme tonight is that these sparks light little fires. And I want to give another example of a spark and a fire. In 2010, there was an article written by the New York Times food and wine critic, a guy named Eric Asimov. And he started this wine review in which he was talking about American Syrah wine. And he started the article with a joke. He said, "What's the difference between a case of pneumonia and a case of American Syrah wine? You can get rid of a case of pneumonia." And the article was all about the American Syrah wine growers who were bemoaning the fact that Americans had not generated a palate for their wines, and they were not selling like they had hoped. So I got a daily digest, a Google News digest. So every news article that had pneumonia in it showed up. And it's always, pneumonia offered to Fort Lauderdale citizens over 65, or some breakthrough in pneumonia research. So a wine thing shows up, and I'm like, that's different. And I looked at it, and I thought, well, if you guys want to get rid of cases of Syrah, we want to get rid of cases of pneumonia, maybe there's something to be done here. So I write a blog for Huffington Post about global health stuff. So I wrote this blog and called it Pneumonia's Last Syrah. And I basically said what I just said now, right? You want to get rid of cases of one, we want to get rid of cases of another. I called up some friends of mine who have a vineyard and said, would you be willing to do something with us? And they said yes, so I had a little quote. And then I posted it. And about 4 weeks later, I get an email from, honestly, the Rhone Rangers, okay? So Syrah is a Rhone-style varietal, and there is a trade association of American wine growers who specialize in the varietals of the Rhone, like Syrah, which basically said, "Are you serious?" And I said, "Oh, yeah." And so they did some due diligence around us, and I put them together with Gavi. And essentially, we did a partnership that year called Pneumonia's Last Syrah, which was hastily put together, but exquisitely executed in the New York Times building during the week of the UN General Assembly, in which we had about 16 vineyards from the Rhone Rangers wineries that poured wine. We had a photo competition that had been judged, and so the winning photos were up around the outside. And we had a series of speakers, including CDC Director Tom Frieden, who's on the right in this picture here. Stuart Montgomery from the left is on the board of the Rhone Rangers. The CEO of Tablas Creek, which is a California vineyard, was one of our speakers, as was, I was one of the speakers, and a couple other folks from the Gavi Alliance, et cetera. And so we didn't make a whole lot of money, but we got a lot more notoriety, visibility, and we sort of penetrated a group of people who weren't, usually thinking about pneumonia, which is the wine community. And I don't know, how many wine drinkers in here? Yeah, I thought. Wine drinkers are way organized. I mean, really, they are connected. They have blogs and Twitter followers and everything. So it was really fun. But it was just a little spark. Now, we also did some fairly seriously minded stuff. So in 2010, we had an event at the Kaiser Family Foundation in Washington, D.C. that was hosted by Cokie Roberts. It included Zeke Emanuel, who used to be with the White House, one of the leading advisors on health. He's a bioethicist from the NIH. Some of you may know. A couple other folks, Dr. Saladin from Save the Children, and a woman from Minnesota who lost her child to pneumonia and talked about that. In addition, in the UK, we had an event. Here's a colleague of mine from Hopkins, Professor Kate O'Brien, with two UK parliamentarians beside her, Lord Avebury and Des Turner, who were part of an all-party parliamentary group in the UK dedicated to childhood pneumonia. So this is like a bipartisan caucus in the United States. It's a set of parliamentarians who put their name to a cause, and so we had an event there. Now, we also decided to be just a little bit outrageous, and we bought a bunch of blue Lycra suits for pneumonia fighters, and so we put them out on the street. And I got to say, this was remarkably contentious within our coalition. There were a bunch of folks who thought, this is the stupidest idea I have ever heard. And why would you use any money at all on this? And some others who thought, I like it, kind of crazy, kind of different. My personal opinion is that these little blue Lycra suits have been worth every penny and more. They're now in their third season of use, believe it or not, which is just remarkable that year after year there are people who will put on blue Lycra, but there are. If you go online, one of the videos that you'll find online is a bunch of Johns Hopkins students dressed up in blue Lycra performing an interpretive dance to the song Breathe in the middle of Johns Hopkins campus. I mean, this is true commitment to the cause. The examples I gave you right now are really about DC and London and Baltimore and places like that. But the most important thing about World Pneumonia Day, by far, is that the sparks lit fires around the world. I mean, clearly, it may have taken that hedge fund to get us started, but there was tinder out there just waiting for an opportunity to do something about this. Here's some pictures from 2009, 2010. There's 2011 ones. There's 2012 ones. There's already a video on the web right now from Bangladesh and this year's march on Parliament. So not only are they doing it, they're doing it year after year to raise awareness of this issue and start to drive governments towards better policies. And I continue to be amazed at the relatively unlikely places where this happens. I mean, people are rallying in places like Sudan and Myanmar, which are not typically the places that we, expect sort of freedom of expression, and yet somehow people feel sufficiently strong about this that they take up the cause. Now, if this will work, I wanted to also show you a little video that is my favorite video from World Pneumonia Day, and I'll show it to you and then just explain. Ma'am, I just wanted to say thank you for wearing your World Pneumonia Day sticker.
Oh,
What'd you think of the blue guys?
I thought they were okay. They're fine. I would have died of pneumonia when I was about 10 years old if it hadn't been for antibiotics. And so, of course, I care about the millions and millions of kids who don't have access to antibiotics.
Thank you for caring, ma'am.
Well, I'd be a pretty selfish person
Okay.
not to.
You probably couldn't hear that, so let me tell you what she said. This is a woman who I met on the street in D.C. right before the event I described at Kaiser Family Foundation. So we had people in the blue suits jumping around. We were giving out little buttons and things like that. And I said, thank you for wearing your sticker. And she said, of course I'm wearing my sticker. I almost died as a child of pneumonia, and antibiotics saved my life. And my heart goes out to the millions of children around the world who live without access to this. And I said, thank you for caring. And her spontaneous answer was, I'd be pretty selfish if I didn't care about that. And I put this up because to me it really shows that with just a little flip video camera or your iPhone or whatever, you can just engage somebody in a conversation and you don't know what'll come out. I had other great stories like that, not so great, right? Another story that on a little flip video camera was this woman who I met on the street there at the same street corner. And she said, oh yeah, pneumonia took the life of my older sister. And I said, oh, I'm sorry to hear that. She said, yeah, my name is in part of her name. My parents had a son and a daughter. They both got sick, but they only had enough to pay for one treatment. And so she died, and when I was born, they gave me a name that was similar to her name. So just incredible, the outpouring of real stories, people's own experiences with pneumonia that's possible. And so if you have a cell phone that has a camera on it, you can do this too. So that's a little bit of the history of World Pneumonia Day and how it got started and some of the kinds of stories behind it. I got a lot more I'll tell you over beer later on. But where's World Pneumonia Day going? Well, I think it's going to be integrated, beginning with diarrhea interventions, because that's where the biggest impact is. Those are the two leading causes of child death around the world. So if you look at that map we saw earlier, these are the 10 countries with the largest burden of pneumonia deaths. They're about 62% of all those pneumonia deaths. Well, there's the 10 countries with the largest burden of diarrhea deaths. So you put those two together, like red states and blue states, they're purple. And that's 1 million child deaths a year, focused in those areas. And then if you line up the strategies for preventing and treating pneumonia, strategies for preventing and treating diarrhea, a lot of them are the same. So it really makes sense, given the overlap in the geographies, the many interventions and treatment strategies that are identical, to go this way. Now, I'd be remiss if we close tonight without me saying a word or two about the Gates Foundation itself and its efforts in this area. Those of you who live in Seattle may have seen this, which is really the sort of quintessential statement about the Gates Foundation's view, which is every person deserves a chance to live a healthy and productive life. And so at the Gates Foundation, there is a pneumonia strategy. Some of my colleagues here, Dave Schultz and others, work on that strategy. Much like the strategy I described for you from WHO and UNICEF, it involves protect, prevent, and treat. It has a broad range of investments. It's a major funding effort on behalf of the foundation. And it's an end-to-end strategy that embraces all parts of the foundation. So it's really, a major undertaking of the foundation is against this important child killer. The team that I'm working with, the vaccine delivery team, is got a role in that. And really the ways in which our vaccine efforts help with the pneumonia problem are on accelerating new vaccines. So vaccines against Hib and pneumococcal disease are the new ones that we have right now. Hopefully someday we'll have, RSV and other vaccines that we'd be able to roll out as well. We work to strengthen routine immunization coverage because we do know that in many of the communities where immunization coverage is lowest, pneumonia mortality is highest. And so we're really working to try and reach some of those last mile populations that represent a really significant part of the problem for pneumonia. And we do that in part also by improving supply and information systems, which are really useful for making sure that we're targeting our resources to the right children, the right groups. But the foundation's not the only game in town. Seattle is, very involved in global health. As I was hearing from Jed before we started, there's a massive global health community here, right? Just here at the University of Washington. And now, when you put that together with groups like World Vision and PATH and Village Reach and IDRI and many more, Seattle's got a lot in this area. And then globally, of course, there are many institutions that have been involved: Save the Children, the Gavi Alliance, UNICEF, WHO, the Best Shot Foundation, CDC, Aga Khan, and others. For a local flavor, I would encourage you to drive downtown and take a look at the Pacific Science Center. Their columns there are going to be lit up blue tonight as part of the Paint the Town Blue initiative, which is turning different buildings and structures blue all around the country tonight. So just to wrap up, I think upon reflection, a couple of things that really worked well for World Pneumonia Day that I would recommend as sort of insights for going forward with efforts like this. One is we had to gain agreement on what unites the coalition. Historically, the pneumonia community was divided. The treatment guys didn't like the vaccine guys, who thought that the breastfeeding guys weren't getting it done. It was just, it was not helpful, right? And when we finally got around the table, we really pointed out, we don't disagree actually on much. We agree on a lot more. And finding what united the coalition to begin with was really key to getting the coalition built in the first place. We developed some simple messages: the prevent, protect, and treat. And those simple messages then were amplified by everybody. So even if you were Save the Children, which was a traditionally focused on community case management, or a Gavi Alliance, which was traditionally focused on the vaccine stuff, on World Pneumonia Day, everything you put out was all about the comprehensive package. And so we did Save the Children and Gavi events, which had never happened before, but it happened around this. And it really helped to bring our community together and get everybody focused on the big problem, which was pneumonia. Which takes me to the next one, which is it was really about raising the issue and not yourself or your institution. It was really about World Pneumonia Day and pneumonia and the issues and the comprehensive package and the sort of, the branding and the contributions of individuals and individual institutions was way secondary to the World Pneumonia Day effort. And then I think one of the other things that's really, really strikes me is the use of small grants as sparks to light lots of those little fires. There's just remarkable amount of tinder out there that is just looking for a match to light it. And we have used small grants since the beginning of World Pneumonia Day. And these are grants that are under $25,000, mostly under $10,000 to people in countries. And those are the guys and ladies who come up with dance-a-thons, soccer games in Kinshasa between the medical community and the journalists, hot air balloons, marches, those big giant lungs that go down the street. They come up with the most creative of ideas for a really small amount of money because all they need is that little spark. So I guess I just want to really stress that each of us can make a difference. You can make a difference in World Pneumonia Day and throughout the year. And I hope you will take today as a spark. I hope that, maybe you came here just, to hear a little bit about pneumonia, but maybe what you'll do is just whip out your phone or like a page on Facebook or just, do a little something that you might not have done today just because you never know. Maybe that little spark is gonna lead to your own fire. there's lots of things that you can do. If you want to do a little bit more, you can donate. You can ask 5 people about pneumonia. You can get vaccinated yourself, which is often a really good idea. And if you want more ideas, the worldpneumoniaday.org website really has a lot of them. So with that, I just want to say thanks for hanging out with me.
So I think we can take a few questions here, and then we can disperse upstairs and have more informal conversation. But if people do have questions about World Pneumonia Day, about your recent introduction to the foundation and what your plans are, anything, please. I would just ask if you can repeat the questions so that we can make sure we get them. Thank you.
Any questions? Yeah.
I have a question, and this is pretty specific about vaccine strategy, but I figure that's one of your topics.
I should know it, shouldn't I? Yeah.
I'm a neonatologist here at the University of Washington. My name is Jana Patterson, and I'm particularly interested, of course, in preventing pneumonia and invasive pneumococcal disease in the first 4 weeks of life. Mm-hmm. I'm wondering if you could just comment on what you see as the utility of maternal vaccination versus early infant vaccination, and if you think those two strategies could feasibly be combined, or they must stay separate.
Okay. So the question is about prevention of invasive pneumococcal disease early in life, in the neonatal period, and or pneumonia, and the potential role of maternal, say, neonatal or early infant immunization and other strategies. Let me take pneumococcal disease for a beginner, because that's one of the examples. I think there's 3 ways that we can reduce pneumococcal infections in neonates. One is we could do maternal immunization and use passive antibody to transfer to the neonate. 2, we could vaccinate neonates and try and actively immunize them from the day that they're born. And 3, we can attain high immunization coverage in the community and interrupt transmission back to them. The third strategy, we have some evidence from rich countries, has an impact. In the U.S., invasive pneumococcal disease from the strains in the vaccine, at least in the 7-valent vaccine, this is data that's a couple years old, but it was down by about 45 or 50% in the neonatal period as a result of vaccinating their older kids and reducing transmission. And that's not surprising, because what we know from from pneumococcal conjugate vaccine use is it reduces colonization in vaccinees, interrupts transmission, and actually, after a while, transmission of the vaccine types becomes very low. We also know that some limited studies, the one that I'm most familiar with is one that was conducted in Kenya with 7-valent vaccine, were able to document that you could safely give the 7-valent conjugate in the neonatal period and elicit some immune response. There's been some work done on the maternal strategy, but not as large of studies as probably would be needed to determine really the protective efficacy. There was one happening here in the United States when the PI actually died, Scott Giebink died, and I'm looking at Jan. I don't remember, Jan, if the results of that study.
They're supposed to be. They had to redo all the serology. It's probably going to come out. I was just talking to the new PI. I think it's going to come out at the end of the year.
Okay, great. So I think that there is some movement in the field on understanding the sort of the immunology, maybe I don't think that study had enough events to have a sort of protective impact. So I think those are strategies that are still under development and could end up either in partnership or one or the other contributing to control. Now, for some other infections like RSV, for example, where a lot of the disease is really shifted into those young kids, without the maternal or neonatal, it might be nearly impossible to impact that kind of disease. So I think it's going to vary by etiology as well. But certainly there's lots of exciting stuff, and nobody knows more about that than Jan, so I'm not even going to try to say too much about that, but those are promising strategies for some of those infections. Other questions? David?
David Schultz from the Gates Foundation. I wonder if you could say a little bit about the role of indoor air pollution and pneumonia as an infectious disease. As an epidemiologist, I can't say that indoor air pollution is the first thing that I reach for, but I understand it might be an important contributor.
Yeah, thanks for that question. The question's about indoor air pollution and its role in pneumonia. So indoor air pollution, in sort of 2 minutes or less, is a sort of well-proven risk factor with strong biologic plausibility to its role in increasing risk. So there's a number of studies that have shown that there's an increased risk of severe ALRI or pneumonia in people who have exposure to high levels of indoor air pollution. And there's it's almost common sense for anybody who's ever walked into a smoky room and felt the irritation, that irritation could make you more susceptible to pneumonia. What's been more difficult is to document the reduction in pneumonia as a result of the reduction in indoor air pollution. And so the clean cook stoves are a technology that could potentially make a really important contribution there. But the first generation of cook stoves did not consistently reduce indoor air pollution, I think, as much as they needed. And so there's a lot of work going on right now to try and make better interventions in cook stoves and things like that. And there's real hope that if we could have the kind of intervention that gave a really robust reduction in indoor air pollution, that we could also subsequently show a significant impact on the risk of pneumonia. But just fundamentally, I think it's really important to remember that there are environmental contributions to the risk of pneumonia, and for those of you interested in the environmental sciences, there's quite a lot of work to be done in that area as well. Yes, please.
You mentioned community case management. I was wondering if you would want to make a comment on integrated community case management by community health workers versus management of pneumonia at a health facility.
Yeah. So I'll make two comments on that. The question is about community case management as opposed to facility-based, and about integrating it. First of all, we know from really well-designed studies, most of which were done in the 80s and early 90s, that if you give community health workers training to recognize children with tachypnea and antibiotics, and they give them to those children, they will reduce their risk of death. So we know that that can be done, and when it's done, it works. So community case management outside of the health facility is an important adjunct to quality health facility care as well, particularly for communities that may have a lot of difficulty accessing health facilities all the time, and where systems may not provide quality health facility care all the time. The other important thing that's happening, though, and in April of next year, WHO and UNICEF will come out with a global action plan for the integrated management of diarrhea and pneumonia, including case management. And that's really important, too, that when we're doing these programs and doing the outreach to these communities at risk, that we recognize that the children there are not just at risk of pneumonia or just at risk of diarrhea, they're at risk of both. And we can combine those two and make a big impact on those.
You would also mention in there malaria?
Absolutely. For the communities where malaria is a big problem, this is an increasingly important integration step. And what's really interesting, I think, is that in a lot of places where malaria control efforts have been ramped up and malaria has started to go down, and they're using the rapid diagnostic tests, they're getting negatives on the tests from kids who are clearly still sick. And the health workers are like, well, what do they have and what should I do for them? I know it's not malaria, but what do I do? And I'm sure quite a lot of that is going to be, other febrile illness and pneumonia. So it's very important that we integrate those things. I think I saw a hand up in the back there. So, great question. The question was, what about the epidemiology and etiology of pneumonia in developing countries? So first of all, in the epidemiology is quite similar in terms of age distributions, risk groups. There are some differences in risk. So absolute risk differences. The risk of severe pneumonia is generally higher for the same age group in an impoverished community where there's high indoor air pollution and all those kinds of things. There are some host risk factors like sickle cell disease in parts of Africa that will amplify the risk of serious infections. Obviously, untreated HIV disease is a huge risk factor, increases the risk of pneumococcal disease by 40-fold. One area that's really poorly understood, though, adults. Adult pneumonia epidemiology is really pretty underwhelming in many of those parts. To the etiology, the bulk of the etiology work that was done to articulate what we think we know about the etiology of serious pneumonia in kids was conducted in the 70s, 80s, up to really early 90s. So for essentially 20 years, we've not really invested in that work. Now, we're applying vaccines against the two leading causes of serious and fatal pneumonia, Hib and pneumococcus, that were identified out of all those. So we've not only not studied it, we are actively changing those patterns. And so one of the big parts of the pneumonia strategy at the Gates Foundation is a project called PERCH, the Pneumonia Etiology Research for Child Health Program, which I was the PI of at Hopkins before coming here. And anybody who's interested in pneumonia etiology research, I would encourage you to check out the website because we built it to be kind of pneumonia etiology research in a box. There's all the clinical protocols, all the forms, basically all the stuff that you would need to kind of set up a pneumonia etiology research project are all online now. So that is now studying the etiology of pneumonia in kids 2 to 59 months old in 9 places in 7 different countries around the world in a very standardized way using state-of-the-art diagnostics. So I think we're going to have in just a year or two the first of one of the first new looks at the etiology of pneumonia in the presence of Hib and pneumococcal vaccination, and we'll hopefully learn a lot more about what the etiology is going to look like from 2015 forward. Maybe one last question, and then I don't want to get in the way of socializing.
You mentioned at the beginning that we know of a lot of tools that we can use to approach pneumonia. What would you say is one of the greatest sort of barriers to implementing some of those or encouraging certain behaviors? And not just the greatest barriers, but those that are actually, you think, feasible to overcome?
Okay. Well, I think there's a lot of tools, and we need to overcome the barriers, and then there's some tools that we don't have. So the tool that we don't have that I would really love to have is an RSV vaccine, a safe, effective RSV vaccine. I think between that, a rotavirus vaccine, Hib and pneumo, as my pediatrician friend says, it's going to be boring to do pediatrics, right? It's going to go. In terms of the barriers, there are some fundamental barriers that are common everywhere, but there's a lot that change context by context as well. So I want to be careful about over generalizing or trying to put a one-size-fits-all everywhere. But there are still far too many communities where parents do not yet recognize the signs and symptoms of a severely ill child that might have pneumonia. And so we've got to do more community mobilization and education around those signs and symptoms. And then many of the same communities lack the consistent supply of services and commodities that are needed to take care of children well. And we've talked about, antibiotics, and they are life-saving and all that kind of stuff. But to me, the big story for the next few years that nobody's talking about right now is oxygen. Oxygen is such a fundamental part of treatment of serious pneumonia, and most places in Africa, they don't have it. If they do have it, they're lousy at delivering it, and it's erratic in its supply. And I just think there's a great opportunity there with some improvements in technology, thinking about some of the systems to really transform oxygen therapy as well. Thanks. Thank you all for those comments.